clotted dialysis lines? Like even after you cath flow, you get, so then it works for like the next like hour or two and then it...
Okay. Okay, so the most common reason that I've seen, and I had to come in and reinsert the CVC, was when the catheter tip is too high up. That's an inserter problem. That's a really good question. Let's start there. The most common thing I see when I'm consulting or evaluating these hospitals is that the catheter tip is way up in the SVC or in the brachiocephalic. That is going to debatably exponentially increase your thrombosis risk. Okay? I can't help that except do a guide wire exchange for a longer catheter. Now, I know of hospitals that they don't even have longer catheters, no options. That's a problem. And so that needs to be, that's a systemic issue. But that's number one. Number two would be that they're not flushing enough. Dialysis nurses know that they're supposed to be flushing with at least 20 ml. But if they have that catheter way up, they might need to do it with 50. But the problem with that is now you might be fluid overloading them because you have to do 50 for both lumens. And it needs to be high pressure. Okay.
For continuous dialysis, how often would you recommend this treatment?
I don't know the recommendation for that, but I would imagine frequently. Yeah, so let's just say if I was coming up and they asked me at that hospital, and let me give you a specific scenario. I see the x-ray and it's really high up, then how long would you say dialysis is for a patient? Just make up a number.
Oh, well, for us it would be continuous dialysis.
For nonstop. You'd have to do a study on that.
Yeah, we don't have protocol for...
There's no studies on that, yeah.
It's shown to not make a difference.
Yeah.
They're about to release new guidelines, the NIGO guidelines for international guidelines for dialysis. They're supposed to be coming out any moment now, but there is no evidence to show that flushing your CRRT circuit a certain amount of time helps improve catheter function. It's about length, location.
Yeah, I think for us it has to do a lot of times with location. It's like the patient's on pressors, the veins are clamped down, there's probably a right IJ, a left IJ, there's less room for it to function. And then I think it also comes down to who inserts it too. I think sometimes they're in a little high and then they're just like hitting the vein.
Yes, very high. Yep.
The best thing for dialysis catheters, quite honestly, especially if you're at a big academic institution, depending on who's placing the line, and always verifying as a bedside nurse the length of catheter they're grabbing per anatomical. Because the amount of times I've seen physicians grab a 15 for a femoral line, right? You know you're never going to hit blood flow rates of 300, 250 or higher.
Yeah, that's insane. 15 centimeter. I exclusively, the pictures that I have, I mean, I could show you what it should look like if you wanted to take it back with you. In my opinion, all CVCs should be either turned and taped to the shoulder, the back of the scapula, or down the chest. Never on the face. Now, the only time I put it on the face, and it's never happened before yet, but it's for burns. If there's like a burn like here, then I'll just put it on the face because that's the cleanest place to put it. But if I had options, it would always, I'll even tunnel it out. Like I have a video out, I tunnel them out of the way to make it safer so even confused patients can't pull it out. Yeah, good question.